Good morning, everyone. I'm glad to be with you all today. I want to thank the committee for giving me this opportunity to speak to you. My name is Chad Condi. I am a neuroscience pharmacist at the University of Utah Hospital. I work in the neurocritical care unit. I'm grateful to be here for you today, and I'm sure you guys are all like me, and pharmacotherapy was your favorite subject in school, so this should be an amazing presentation for y'all to enjoy. To start off, I just want to reveal that I have no conflicts of interest to report. Also, off-label use of medications will be discussed, and I will discuss trade names along with the generic names or compound names. Here are the objectives for today's presentation. We're going to just talk about preparation and administration of tenecteplase. We'll identify some signs of angioedema. We'll talk about PCSK9 therapy, place in therapy, and we will design a drug therapy plan for post-stroke motor recovery. Throughout this presentation, I will be using several different abbreviations. Most of them are pretty common, but here's kind of the list of the abbreviations you can quickly look over. This presentation has quite a bit in it, so to start off, I kind of want to give you an outline of the way we're going to go. We're going to start talking about tenecteplase, then we'll talk about management of thrombolytic complications. We'll talk about cholesterol goals and agents to use post-stroke, and lastly, we're going to talk about motor recovery and cognition after stroke. So, kind of wanted to include a bunch of different topics in this talk, so that's why it's kind of jumps all over. So to start off, we are going to talk about tenecteplase. Brand name is TNCase. So it is a thrombolytic agent that promotes initiation of fibrinolysis by binding to fibrin and converting plasminogen to plasmin. So its mechanism is very similar to that of alteplase. However, it differs from alteplase in that it is a little bit more resistant to the plasminogen activator inhibitor 1. So it has a little bit longer half-life, which we'll talk about in a minute. As far as dosing in stroke patients, in studies they use both the 0.25 mg per kg and the 0.4 mg per kg, and there's not really an established dose. So most commonly, or most recent studies used 0.4 mg per kg with a max dose of 40 milligrams. This dosing does vary from that used in cardiac literature. So given that tenecteplase is a newer agent, one that many of us maybe not be as familiar with as preparation, I wanted to go through how we prepare it or mix up the drug really quickly. So obviously the first step is we're going to remove the vial toppers from both the vials, and then you'll wipe the top with the alcohol swab as usual. Remove the needle topper from the syringe, then you're going to insert the needle into the sterile water vial and draw out all 10 mils of the fluid. Inject all 10 mLs into the tenecteplase vial. Bubbles may form during this reconstitution process. You need to allow the bubbles to dissipate, and that may take several minutes. You can swirl the vial if needed to help get the drug into solution. You shouldn't shake it. The final concentration will be 5 milligrams per ml. And then you want to withdraw the correct dose from the vial and then discard the remaining amount. Given that most of the max doses will be 40 milligrams, you'll probably end up discarding about 10 milligrams from the vial. So for administration, you want to inject it as a slow IV push over 5 seconds into a peripheral IV line. It's pretty easy, pretty straightforward. Important to not administer it IM or sub-Q. Also important to know that it is incompatible with dextrose, so any dextrose containing lines need to be flushed with saline before and after administration. As far as storage goes, you want to use it immediately after you reconstitute it. If you don't use it immediately, it can be stored for up to 8 hours, but I don't see this being used for another patient, so it's use it or lose it. As far as post-tenecteplase infusion, an important thing to remember here is that it has not been officially FDA approved for stroke, and so because of that, the manufacturer doesn't really have any post-monitoring for stroke. So I would just follow the same recommendations that we use for alteplase, which are neurologic assessments and vital signs every 15 minutes for the first hour post-infusion, followed by vital signs and neurologic assessments every 30 minutes for the 2 to 7 hours post-infusion, and then going to every hour for the next 8 to 24 hours, and then getting a stability scan within the first 24 hours to ensure there's no bleeding. So a quick little comparison between tenecteplase and alteplase. Tenecteplase was FDA approved in cardiac stuff in 2000 versus alteplase in 1989. Tenecteplase does not have that FDA approval for stroke, so it would be off-label, whereas alteplase has FDA approval for stroke. Administration time is probably the other big difference between these two agents, 5 seconds for tenecteplase versus an hour or 60 minutes for alteplase. Half-life is longer with tenecteplase at 20 to 25 minutes versus 5 for alteplase. They're both hepatically eliminated. Cost-wise, 50 milligram vial is going to run you a little over $7,000 for the tenecteplase. With alteplase, you're looking at over $10,000 for the 100 milligram vial, which is what we use in most stroke patients. The biggest difference between these two is the spoil program is not available for the tenecteplase. So if you mix it up and don't use it, you're out that money. Whereas with alteplase, if you mix it up for a stroke patient and you end up not using it, at least you can recoup that money. So with any thrombolytic we use, alteplase or tenecteplase, there is a couple of complications that are very serious. Luckily they're relatively rare, obviously bleeding and angioedema. So if a patient has post-thrombolytic bleeding, signs and symptoms you want to watch for are headache, altered mental status, hypertension or hypotension, tachycardia. As far as acute management, you want to stop the infusion if it's still running, maybe with alteplase. You want to alert the medical team, obviously. Labs to order would be a CBC, PTINR, PTT, fibrinogen, and then you want to type and cross, get that ready, and then obviously a stat head CT. For acute management of CT confirmed intracranial hemorrhage, you generally want to give an antifibrinolytic agent, which would be either tranexamic acid or aminochloroic acid. You can see the doses there. Obviously, over tranexamic acid, we're going to give a gram over 10 minutes versus aminochloroic acid is 4 to 5 gram bolus followed by a gram an hour until you get your bleeding under control. And you will likely need cryo 10 units infused over the first 10 to 30 minutes and may need to repeat, as we did actually in our last patient that bled post TPA. Always important to consult neurosurgery when you got big head bleed. And then for fibrinogen deficiencies, you want to consider consulting hematology. And then obviously we're going to provide supportive care to these patients. The next complication I want to discuss post thrombolytic would be oral angioedema. This is a potentially life-threatening swelling of the tongue, lips, and tissue of the oral pharynx. The incidence of this is relatively rare, 0.9 up to 5%, but that probably be more with people that were on an ACE inhibitor prior to. So anyway, low incidence of ischemic stroke patients that receive thrombolysis. There is that 3 to 4-fold increase in patients that are taking ACE inhibitors prior to administration of the thrombolytic. So a typical manifestation is mild hemifacial swelling, usually on the contralateral side of the ischemic infarct within an hour of the alteplase infusion. Onset varies, however, has been known as early as 10 to 15 minutes from the start of the infusion and can occur up to an hour after the end of the infusion. Here are a couple of pictures. You can see that hemilateral or unilateral swelling, the tongue, lips, and you can also get bilateral. So the pathophysiology or why this occurs, 2 possible mechanisms: a histamine reaction and a bradykinin reaction. Generally speaking, the histamine reaction is through the complement cascade. You get your mast cell degranulation and your histamine release, which leads to that anaphylactic type reaction. But the other kind is the bradykinin. As you can see on the left side of the chart, that you get an increase in kallikrein. High molecular weight kininogen gets cleaved into bradykinin, and it's a bradykinin, this increase in bradykinin, which causes this angioedema. And the reason why ACE inhibitors can be problematic is because ACE inhibitors inhibit these plasmin kinases, and these plasmin kinases inhibit bradykinin. So if you don't have these plasma kinases inhibiting your bradykinin, you get an increase of bradykinin, which can lead you to this reaction. And you know, bradykinin is a vasodilator that can increase this vascular permeability. So as far as initial management of this, you want to discontinue the alteplase if it's still infusing. Obviously you wouldn't infuse tenecteplase anymore, but it's so quickly infused that it's already in. Obviously hold any ACE inhibitors. The initial management that we do generally is methylprednisolone 125 milligrams. You may repeat it if you need to. Benadryl 50 milligrams and famotidine 20 or 40 milligrams. All these are given IV. If the patient continues to swell after this initial management, you can consider using epinephrine, either IM or a racemic mixture of epinephrine nebulized. For refractory cases that don't respond to these, you want to use a C1 esterase inhibitor, Berinert or Ruconest. Those are the doses there. To be honest with you, I've never used any one of these agents. Other agents that are available, these bradykinin or kallikrein inhibitors, which would be the icatibant or the Kalbitor, which is alkylantide. Again, rare. I've never had to use one in the many years we've had, and we've had our fair share of angioedema cases. Generally, you're managed with the initial management. Airway maintenance. Intubation is generally not necessary if the edema is limited to the anterior tongue. If you do get edema of the palate or the larynx, or if you have rapid progression, that may require intubation. Intubation is not always required, and the decision is generally up to the treating physician. Cricothyroidotomy is not recommended, and this generally resolves within 24 hours of administration of the TPA. So as far as post-stroke lipid management, so the Treat Stroke to Target trial came out in 2020 comparing the different LDL goals. It looked at, or it wanted to see if targeting an LDL of less than 70 would be superior to an LDL goal of 90 to 110 in reducing overall cardiovascular events in patients with evidence of atherosclerosis after a stroke or TIA. They had a randomized parallel group conducted at 61 French and 16 South Korean sites. It was funded by the French ministry, along with an unrestricted grant from Pfizer, AstraZeneca, and Merck. Patients were 18 years or older with ischemic stroke in the prior 3 months and a modified Rankin scale of 0 to 3, or a TIA in the previous 15 days, and atherosclerotic disease. And that atherosclerotic disease was defined as a stenosis of extracranial or intracranial cerebral artery, atherosclerotic plaques of aortic arch greater than 4 millimeters in thickness, or a known history of CAD and an indication to be on statin therapy. Patients were randomly assigned to either the less than 70 or the 90 to 110. Investigators could prescribe any type and dose of statin therapy and add any other lipid-lowering agents such as ezetimibe or ezetimibe. LDL was checked 3 weeks after randomization and followed every 6 months. Investigators were encouraged to keep blood pressure less than 130 over 80 for diabetic patients and less than 140 over 90 overall in other patients. And then a target A1C of less than 7, and encouraged smoking cessation. The primary endpoint was a composite endpoint of major cardiovascular events, which included non-fatal MI, stroke, hospitalization from unstable angina, a TIA requiring urgent cardiac revascularization, or a cardiovascular death including sudden unexplained death. Secondary endpoints was kind of the similar type thing individually, MI, urgent coronary revascularization, CV death from any cause. All endpoints were adjudicated by a committee unaware of group assignment or LDL levels reached. And enrollment was from March to December, March 2010 to December 2018. There were 2860 patients included in the primary analysis. So here's just a breakdown of the baseline characteristics. You can see most of them were stroke patients. A few were TIAs. Here is a great graph to show the amount of time that the group spent at the goal range. So you can see on the left-hand picture, the target group was attained for most of the study time, and on the right-hand side, the primary endpoint was statistically less in the lower treatment group than in the higher treatment group or higher target group. So here we can see the endpoints of the trial. So major cardiovascular events were less in the lower target group as compared to the higher target group. You can see there were fewer non-fatal cerebral infarctions or strokes in the lower group. As far as the secondary endpoints, the initial one was not statistically different, so they didn't really run statistics on the rest of the events. As far as subgroup analyses, you can kind of see those that favored the lower group, where were French, or people that were 65 to 75, patients that weighed more than 70 kilos, which is probably most of the American population. Also, patients that did not have hypertension at baseline, diabetic at baseline, benefited with the lower target. You can see the confidence intervals. And then also time and therapeutic range. So the more they spent at the goal range, which was less than 70, they did better than those that didn't or that were higher. The reported adverse events in this trial, ICH, there were 18 patients in the lower group and 13 patients in the higher treatment group. You can see the hazard ratio, confidence interval there. Same thing with new diagnoses, which new diagnosis of diabetes, which they defined as A1C greater than 6.5 on 2 separate occasions. There was 103 people in the lower group and 82 in the higher group. So the author concluded that in patients with ischemic stroke or TIA and atherosclerosis, an LDL of target of less than 70 milligrams per deciliter using statins or ezetimibe resulted in fewer composite major cardiovascular events than those assigned to a range of 90 to 110. Results support the finding from other meta-analyses that a lower level of LDL is associated with better cardiovascular outcomes. The benefit of reducing LDL to less than 50 is not known, but could be looked at with other studies, and we'll mention it a little bit in the next studies. As far as my conclusion, I think we should treat stroke patients to an LDL less than 70, especially those with atherosclerosis. And to do that, I believe we should use maximally tolerated statin therapy, ezetimibe, and or a PCSK9 inhibitor if needed to achieve that LDL goal. So, since I kind of mentioned them, let's talk more about PCSK9 inhibitors. So, proprotein convertase subtilisin kexin type 9. That's quite the mouthful, so that's why we just say PCSK9. So PCSK9 is an endogenous thing that binds to our low-density lipoprotein receptors and promotes the destruction of these receptors. So if you look in our little diagram there, our LDL receptors work to bind LDL cholesterol. They bring it down, and you get a breakdown of the LDL cholesterol, and your LDL receptor goes back up to catch more LDL that's circulating around. Well, these PCSK9s bind to these LDL receptors, and they cause a breakdown of the LDL receptors. So therefore you have less LDL receptors, therefore you have less LDL cholesterol being removed from the bloodstream. So basically our PCSK9 inhibitors go and they inhibit that binding and that breakdown of our LDL receptors. So we have two FDA-approved PCSK9 inhibitors, evolocumab or Repatha and alirocumab or Praluent. They were basically FDA approved at the same time, a month apart. They both are dosed for cardiovascular prevention. They both have a Q2-week dose of 140 for the evolocumab and 75 to 150 for the alirocumab, or a once monthly for both of them. Initial onset is similar, 4 hours for both of them. They both peak about the same time. They're both metabolized by proteolysis, and they have somewhat similar half-lives. I guess the evolocumab is a little longer, 11 days, versus the alirocumab. Price pretty similar. Obviously, they got to be competitive with one another, so price per dose is pretty close. So there were two main trials that looked at these drugs, and they were the Odyssey and the Fourier trials. They were both published in the New England Journal of Medicine. One was in 2017, the other one was in 2018. So Odyssey outcome, they were both multi-centered, randomized, double-blind, placebo-controlled trials. In Odyssey, there was 18,000 patients. Fourier had 27,000 patients. Both of the patient populations had LDLs greater than 70 on statin therapy. It's important to note they're on statin therapy and they were still greater than 70. So the dose they used for the alirocumab was 75 every 2 weeks. Evolocumab was 140 every 2 weeks. And then the primary endpoint was composite of cardiovascular events. And follow-up was between 2.8 and 2.2 years. So obviously each drug was funded by their manufacturers, so Sanofi and Regeneron for the alirocumab and Amgen for evolocumab. So these worked really well. As you can see here, the mean LDL cholesterol throughout the study time was less than 60 most of the time. As you can see, months since randomization up to 48 months out, it was down to 66, so definitely less than 70. As with the evolocumab, we're looking down less than 40 most of the time, which was statistically better than the placebo group. Here are a couple of the endpoints discussed. So there were statistically less cardiovascular events in the alirocumab or in the evolocumab groups. Also, composite death from any cause was less in the alirocumab, as well as you did have fewer non-fatal or fatal ischemic strokes. Same thing you can see with the evolocumab. Stroke was statistically less with that group that was treated with that as compared to the group that was treated with just a statin plus placebo. So the author concluded that patients on high intensity statin and LDL greater than 70 had fewer recurrent cardiovascular events if they were treated with alirocumab as compared to just placebo. And the Fourier conclusion was pretty similar. So inhibition of PCSK9 with the evolocumab on a background of statin therapy lowered LDL levels to a median of 30 milligrams per deciliter and reduced the risk of cardiovascular events. The study shows that patients with atherosclerotic cardiovascular disease benefit from the lowering of LDL cholesterol below current targets. After reading these studies, I would agree that addition of a PCSK9 inhibitor should be considered in patients who do not achieve their LDL goal of less than 70 on maximally tolerated statin therapy or ezetimibe. Consider adding to patients with recurrent atherosclerotic strokes on maximally tolerated statin or ezetimibe. So as far as approval process, because these agents are still rather pricey, the process that we use at UHealth will be discussed, but kind of some reasons why we use PCSK9 inhibitors in stroke patients are the ones that have a LDL greater than 70 that are already on maximally tolerated statin therapy. If they've had a recurrent stroke with diffuse atherosclerosis would be indications for it. Use use the agent that's preferred by the patient's insurance carrier. That's obviously pretty straightforward. And then some insurers require prescription to be from a cardiologist or an endocrinologist, which seems kind of silly. Here's the process, as I mentioned, for the UHealth clinic process. So the provider requests a PCSK9 inhibitor for the patient and states medical need in a clinic note. Prior authorization is applied for by specialty pharmacy team. Specialty pharmacy gives updates on process and requests additional information if needed. And then, depending upon what happens, we go to step 4 here. So medication is either approved, and if it's affordable, the clinic pharmacist calls the patient to provide education and arrange delivery. If the medication is approved but not affordable, the specialty pharmacy team will get patient in contact with patient assistance to help them afford it. If the medication is not approved, the provider can then submit an appeal to the insurance company and try and work through it that way. Lastly, are side effects of PCSK9 inhibitors. Injection site reactions, probably the most common. Up to 17% of people complain of those. Nasal pharyngitis can occur up to 11%. Hypersensitivity reactions up to 9%. Influenza-like symptoms in 6%, diarrhea in 5%, and hypertension up to 3%. As far as monitoring goes, you want to monitor a baseline lipid profile, and then maybe 4 to 12 weeks after starting therapy, check it again, and then every 6 to 12 months after that. And you want to just be aware and watch out for hypersensitivity reactions. The other agent dealing with cholesterol that we're going to talk about is Vascepa, or icosapent ethyl. So this is a highly purified icosapentaenoic acid ethyl ester. Sorry. Use is approved for cardiovascular risk reduction in mild hypertriglyceridemia. So it's generally used for patients on max statin therapy with a triglyceride level still greater than 150 with cardiovascular disease, or if the patient is diabetic and they have 2 or more risk factors for cardiovascular disease, then you could consider using it. Dose is generally 2 grams twice daily with meals. Adverse effects include hemorrhage, major hemorrhage, which would be in the head, 3%, or serious GI bleed, AFib, aflutter, peripheral edema, gout, constipation, musculoskeletal pain. And some post-marketing adverse effects include increase in serum triglycerides, diarrhea, and abdominal distress. So for monitoring, we generally check triglycerides, LDL, LFTs, and then you watch for signs and symptoms of bleeding. Cost is about $3.50 per capsule, which comes to be about $412 a month, or nearly $5,000 a year for this therapy. Seems like a lot for just a triglyceride therapy, so what data is out there to support its use? And the biggest one is this Reduce It trial. It's published in the New England Journal of Medicine in 2019. And it was a randomized clinical trial, double-blind, placebo-controlled. Mineral oil was the placebo. More on that in a minute. Patients, they had over 8,000 patients underwent randomization. Inclusion criteria were patients over the age of 45 with established cardiovascular disease, or if they were over 50 and they had diabetes and 1 additional risk factors. Their triglycerides had to be between 150 and 499, and LDL had to be between 41 and 100 on a statin. So they excluded people that had heart failure, liver disease, if their A1C was over 10, if they had a life expectancy of less than 2 years, if they had a planned coronary surgery, or if they had an allergy to shellfish or fish or any of the other drug ingredients. Intervention was icosapent ethyl 2 grams twice a day with food, or placebo. So it was sponsored by Amarin Pharmaceuticals. Sponsor was responsible for collection and management of the data. Sponsor was on the committee, developed the protocol, and interpreted the data. So a lot of industry support and help on this trial. Primary endpoint they looked at was similar to our other ones that we've been looking at, which was composite of cardiovascular endpoints, so our death, non-fatal MI, non-fatal stroke, unstable angina. Secondary endpoints was individually composite of CV death, non-fatal MI, or stroke. Time of the trial was first patient was enrolled in 2011, near the end of the year, November 2011, and the last patient was enrolled around August 2016, July-August 2016. Big things to note with this is first protocol amendment was in May 2013. This changed the lower limit of acceptable triglycerides from 150 with an exception to 200 and no exception. So initially they said we'll take any patient that has a triglyceride level of 150, give or take 10%, so you could have basically 135 or above be included. And then after 2 years they said nope, we're switching it, you have to have 200 or higher, no exceptions. They also had a second protocol amendment changing the secondary endpoint in July of 2016, and the study enrolled their last patient in August 2016. So here's kind of the characteristics of the patients, pretty straightforward, pretty similar between all of them. You can see the LDL cholesterol, and here's the triglycerides, how initially there were some patients that had less than 150, and then later they made the changes, and then the majority of the patients were over 200 milligrams per deciliter of triglycerides. So here's a look at the primary endpoint. Statistically better or statistically fewer cardiovascular endpoints in the icosapent group as compared to placebo. Same thing with secondary endpoints. And to start to see the separation takes between 3 and 4 years before you really start to see some difference in patients. I found this one really interesting because the hazard ratios showing icosapent better, nearly every single one of them. So primary composite better, key secondary composite, cardiovascular death, and the p-values are really significant, less than 0.001. Everybody but death from any cause showed that icosapent was a better option. Side effects. So this is where it was kind of interesting that they chose to use mineral oil as the placebo. They did it as an effect to try and make it look like, oh, it's an oil type thing, but what ended up happening is you got more patients on placebo had diarrhea, which was statistically significant than in the treatment group. You also saw more peripheral edema in the treatment group. Constipation was statistically higher in treatment group, as was AFib, which was kind of surprising. And anemia was higher in the placebo group. Not exactly sure why that was the case. So the authors concluded that this trial, that the number needed to treat to prevent primary outcome is 21 patients, and the secondary outcome was 28 patients. Trial results should not be generalized to other N3 fatty acid mixtures, which are variable and unregulated and have shown no clinical benefit. And where that's coming from is there was a study done in Japan called the JELIS trial. They looked at using the same icosapentaenoic acid in patients, and they found that patients for secondary prevention had no change, people that were on it versus not. So they're saying it doesn't apply this, our benefits were seen whereas other ones weren't. And then another thing that was interesting with this conclusion was cardiovascular benefits were similar across baseline levels of triglycerides, and that benefit was seen regardless of the attained level of triglycerides. Also, among patients with elevated triglyceride levels on current statin therapy, the risk of major ischemic event was significantly lower with 2 grams of BID of icosapent compared to placebo. My conclusions, icosapent ethyl appears to be another great addition to secondary cardiovascular protection. However, I do have some major concerns with this drug. I didn't really like the changes in the protocol throughout the trial, especially the one on the secondary outcomes right near the end of the trial. And then using mineral oil as a placebo led to several adverse events in the placebo group. There was this bleeding issue and new AFib with icosapent. And these results differed from other N3 fatty acids, and they said, well, the dose we used was different and different patient population, so that's why we saw benefit where the other ones didn't. But given all those, and there are a lot of other groups out there, lipid groups that recommend it, so possibly consider this agent. for use in patients with continued events while on maximally tolerated lipid-modifying agents such as statins, ezetimibe, and PCSK9s. So the last thing we're going to talk about in this presentation is SSRI and motor recovery and Ambien for cognition. So a little history on this SSRI and motor recovery. The FLAME trial was published back in 2011, and I remember afterwards everyone was getting put on fluoxetine. Anyone that had a stroke for motor recovery, put them on fluoxetine. 2012, this Cochrane review came out showing 52 randomized trials showing benefit. Article in 2016 in the Current Opinion in Neurology stated benefits of SSRIs after strokes, and things were going well. And then we had these two trials in 2020 that came out that kind of had some negative effects. So we're going to look at these new negative effect trials. So they are the Affinity and the Effects trial. Now these were published in August of 2020, both of them in the Lancet Neurology, and there was lots going on in August of 2020. To say the least. So these probably didn't get looked at by a lot of people, so that's kind of the reason why we want to bring it up here. The patient groups for Affinity was Australia, New Zealand, and Vietnam. They enrolled about 1,200 patients. And the other one was in Sweden and enrolled about 1,500 patients. As far as fundings, they were both funded by the national services, so National Health and Medical Research in Australia, and then the Swedish Research Council and several Swedish foundations funded that one in Sweden. Both of them looked at placebo 20 milligrams daily, fluoxetine 20 milligrams daily compared to placebo, and they followed them for 6 months. You can see the breakdown of the populations. Obviously, the Affinity was in Vietnam as well, so they had more Asian populations as compared to the Effects trial, which was in Sweden and was pretty much all white. Ischemic stroke was, as is normally, 88% of the patients that were enrolled in these studies. As far as some of the other results, as you can see, there was no real change in anything except for mood and emotional control was better in the fluoxetine group, which you would hope to see. So in both of them, mood and emotional control was better with the fluoxetine group. The big change was the side effects. So these are things that we haven't seen a lot with, but they noted in their trials that were statistically significant. Epileptic seizures were higher in fluoxetine group. Falls with injury is this noted in the Affinity trial. New bone fractures, and this one noted hyponatremia, although it wasn't significant. However, in the Effects trial, it did note significant hyponatremia, which was statistically significant. They also noted diabetes, and then again the bone fracture. So some new things to be concerned about, watch for with these agents in stroke. So the Affinity study authors concluded that fluoxetine does not improve functional outcome after stroke. It likely improves mood, but more likely to cause falls, new bone fractures, and seizure. And the Effects group stated that fluoxetine did not improve a patient's functional outcome after stroke. Patients with new diagnosis of depression was lower in the fluoxetine group, and fluoxetine patients had more episodes of bone fracture and hyponatremia than placebo patients. My conclusion overall is fluoxetine use after stroke should be more for depression than for motor recovery. So I'm not saying we shouldn't use it anymore, just saying it should be used more for depression. So what to use? With these new negative trials, it makes it difficult to recommend fluoxetine for post-stroke motor recovery. And in fact, the European Academy of Neurology and the European Federation of Neurorehabilitation released a guideline in 2020 recommending citalopram 20 milligrams a day for early motor rehab after stroke. It was a very weak recommendation, and they recommended only the 20 milligram citalopram and not the 10 milligram dose. So very specific on that weak recommendation. My conclusion is I would say restart a home SSRI if the patient's on one. Starting a new SSRI post-stroke would be to help with mood and depression and not for motor recovery. Just don't feel like there's enough data to support that. And then in any patient you put these on, watch for falls, fractures, hyponatremia, and possibly even seizures. So that leads us to our last topic, which is zolpidem. Is it a wonder drug? So one of the residents on rounds a while back said, "Hey, I want to try Ambien on these patients because I heard it's great for cognition." So I wanted to look into this a little bit more, and I thought, Ambien, that seems kind of strange. It'll help wake somebody up. So let's see what kind of data is out there. Well, in 1997, there was a case report of a Parkinson's disease patient that experienced significant improvement in rigidity after a dose. Well, later in 2000, there was a case report of a man in a vegetative state for 3 years after a TBI that suddenly awoke and communicated with his family after a dose of zolpidem. This led to many more case series and reports that saw more benefit. In 2017, JAMA Neurology reviewed the efficacy for non-insomnia neurologic disorders. They reviewed 67 articles looking at zolpidem for movement disorders of consciousness, and other neurologic conditions. And then there's 9 of those studies that looked at zolpidem use in stroke patients. And looking at all of these studies, there was 3 I'll talk about, but before, the proposed mechanism that they think of why Ambien may help with this is because it acts on the omega-1 subunit of the GABA-A receptor. These omega receptors are located in the output structures of the basal ganglia, especially in the globus pallidus, interna, and the substantia nigra, pars reticularis. These structures send the inhibitory signals to the thalamus, down to the frontal and motor cortices, where arousal and motor control are regulated. So they think that Ambien restores the function by inhibiting the inhibitory areas in the thalamocortical circuitry. Before we go over the studies, these are the scale they use, the coma recovery scale. It's a 23-point scale. Obviously, higher scores are better, means the patient's more awake. It's broken down into 6 subsections, and you can see the breakdown. And this was the scale used in all the studies. Quickly just mention. So of all those 67 plus studies, there were 3 that actually had more than 1 or 2 patients, and these were the 3. There were two U.S. studies and a Belgian study, and the cause was either TBI or anoxic brain injury or cerebrovascular accident such as stroke. Time from diagnosis varied between 4 months to 26 years. Sample size was 60, 15, and 84 patients. Average age was 35, 38, and 36. The dose they used was 10 milligrams, and then the outcome was that CRS scale, coma recovery scale revised. And 12 of the 60 patients saw improvement in the one study, 1 out of 15 and 4 out of 84. None of them were really significant. Duration of effect was not listed, or it was transient, lasting up to 4 hours in the white study, this first white study, and only 2 hours in the second white study. As far as adverse events reported, none or sedation. So conclusion, few to no quality randomized controlled trials on the subject. Most data are case series and case reports. Effects are transient, they wear off as the drug wears off. Some patients did see some significant improvement, but there was no noted predictors of response. And most common dose used was 10 milligrams, although there was a study used up to 40 milligrams. My conclusion after reviewing this is data does not support routine use of Ambien or zolpidem to treat disorders of consciousness after stroke. There's been no quality randomized controlled trial data to support the use for other indications. However, there is a low risk of harm, maybe sedation, and a low cost to trial the medication, so if you want to give it a try, I guess go on ahead. Overall conclusions to this whole kind of hodgepodge of things. Tenecteplase, not FDA approved, but can be used in stroke. Use same monitoring for tenecteplase as you would for alteplase. Angioedema is rare but serious side effect of thrombolytics. Consider using steroids, diphenhydramine, famotidine. And go LDL after 70, of less than 70 after stroke. PCSK9 inhibitors should be considered third line after a statin and ezetimibe. Recent negative studies have diminished the luster of fluoxetine for post-stroke recovery, and zolpidem not likely to cause any lasting improvement in cognition. Here are the references I used, and any questions.